Now, this is a scoring that I would like everyone to know, according to which an eye transplant center allots the eye, or an eye bank may allot the eye. So, if the visual disability is bilateral blindness, then you get a higher score. The higher score you have, the more likely that you're going to get the tissue. Now, if you have a condition which can give very good visual outcome, like the bullous keratopathy I talked about before, you have a higher score. Now, if you are in the age group that is young and you need vision so that your eye doesn't become lazy, then you get a higher score. But if you look at the other conditions, where there are associated comorbidities, like with a lot of deep vascularization, you have uncontrolled glaucoma, you have other pathologies in the retina, or you have a squint, then you may not be a high scorer. Again, an emergency graft requirement, like if you have perforated corneal ulcer, that would be a high score. So these are conditions depending on which the eye bank allots tissues, or the transplantation center allots tissues. Now, if you have a full-fledged eye bank, that is a huge process requiring a large amount of investment, and this eye bank will be able to spread public awareness about donation, should be able to procure tissue, should have counselors to do all these things in various medical departments and to educate other such counselors. They preserve the tissue using various types of media, and now even pre-cut tissue is available. So earlier the whole corneoscleral rim was available for transplantation. Now you have different layers of the cornea that may be available for transplantation. And then they need to distribute. So they need to have a good network with various transporters and flights, so that cornea can be transported to different regions depending on the requirement. There is actual triad system that you have to disperse the cornea locally, then into the state, and then you can disperse nationally and regionally, followed by nationally, and only then can you give this cornea to an international visitor, or and even before that international person, a person of Indian origin who may be a resident abroad is given a priority. Then fundraising. Applying for charitable societies and getting them to be involved in this process is very important. So this is a summary of whatever I had said during this. What I would like to highlight is that cornea may be retrieved by an ophthalmologist or by any person who has undergone a medical course or a paramedical course, provided they are trained in such retrieval. So that is the clause for retrieving of the cornea. Another thing we keep on telling our patients, and we keep on telling our potential donors, and we keep on spreading awareness about, is that corneal transplantation or procurement of the cornea does not disfigure the eye or does not delay the procedure or whatever rituals need to be followed after death. And even suppose you want an open casket funeral, that can also happen. So there is no bar to any of these things. So these are things that that lie like a doubt in the layman's mind, which you may need to clear. Because we just take the corneoscleral rim. Earlier the entire eyeball used to be annihilated. That's not very common now, because preserved sclera can always be taken out from the corneoscleral rim. But an annihilation of the entire eye is very rare. So we take the corneoscleral rim and we replace it with some similar kind of an artificial device, so that the eyeball does not sink, the lids are sutured after that. So there is no disfigurement. And those who procure the tissue are also protected legally. They cannot be sued for any form of mutilation. Now, what is important is that the depth DTPT, or depth in preservation time, is very important. Earlier we used to say that it's 6 hours, but it has been extended up to 10 hours now. But the type of media that we use have also increased, and they have increased the duration after which a cornea can be transplanted, and also the distance it can travel for transplantation. So this is the time that you need to get consent and convince the relatives and procure the cornea and take the consent forms, check out the medical history, and so that is why the led to preservation time, that the time period during which all this is done is important. Now, in India, donor screening, basically, these are the things that you have to remember might be an obscure meant to procuring the cornea. So, the middle paragraph where the disease is confirmed, you should not be procuring a cornea from are these. So, namely, rabies, Creutzfeldt, Jacob, or any form of prion disease, any form of hepatitis or herpes simplex virus. I'm talking about known cases. And carcinomas of the eye, basically, or metastatic carcinomas that can affect the eye. And extreme ocular bacterial infections, those that have obvious ocular infection. So, then the rest are relative contraindications. So, known transmission of viruses, even the cases are anecdotal. I don't know whether because the reporting has not been very good or whether actually they are few of viruses is low. So, what we usually do is we procure the cornea and then we tally with the medical sheet and the history, the person who has provided the history and the medical charts to decide whether the cornea can be used or not. Now, age here is an important factor. Some countries have laws which decide what age group can donate. But in India, we don't have a lower or upper age limit, but in general, we say that less than 3 years and more than 80 may not be a good candidate to donate their eyes. First of all, less than 3 because the cornea is very elastic. The tissues are very immature and they don't behave during surgery or later on post-operatively like an optimal tissue. So that the purpose for which they are used may fail. The second is with age you have degeneration, attrition of the corneal endothelial cells, because of which the clarity of the cornea may not be maintained, and with age you might have undergone surgeries inside the eye that may also have compromised endothelium. Though as such, any surgical procedure like extraction of cataract or implantation of an intraocular lens or having undergone a glaucoma surgery or any form of laser is not a contraindication to corneal transplantation, to donating the eye. Now, there are some high-risk individuals that have been excluded, so this is mainly in the US, but we use some of the same criteria from donating eyes. Now, storage of the cornea, now this is basically an off-the subject, there are multiple types of media. So, one of the earliest media was the MK media, but it can hold only for a short duration. Then you have various media with chondroitin sulfate and tissue culture infused into it. Which makes it able to store the cornea for a longer time, usually between 1 and 2 weeks. Then you have temperature preservation that can preserve the cornea for much longer, let's say a month or so. But here, please remember that the viable endothelial cells may die out and it's not suitable for the full tissue preservation. So here, tissue may be preserved if you're talking about the sclera, or if you're talking part of the cornea like the Bowman's membrane or the stroma, that needs to be used for a part lamellar transplantation. So the endothelial cells tend to get damaged due to the thawing and the cryopreservation methods. Now, grading of tissue is an important function undertaken by the eye bank. So after procuring the tissue is kept in a preservation media. It is examined under the slit lamp by a microscope. It is examined under a specular microscope, which is different from the one used in humans, to make sure that the quality of the tissue, what grade does it fit into. So you have various criteria to decide that. One is depending on the morphological appearance of the tissue. The other is the number of cells in the tissue that are viable. Now that decides on whether this tissue, like I said before, is good for a very optical purpose, like clearing the edema in a person with very good vision, or whether it should be used for a therapeutic or a tectonic purpose, like getting rid of the fungal load from an eye and instead replacing it with corneal tissue. Now, the different ways in which tissue can be utilized is by a full thickness penetrating graft of the cornea. Here, the tissue sizes can vary from 6.5 or 7 millimeters to around 11 millimeters. Then lamellar keratoplasty, that can happen to the anterior part of the cornea. Suppose you have scar in the anterior part of the cornea, then only that much of tissue needs to be replaced. That can happen right superficially in the form of an anterior lamellar keratoplasty, or slightly deeper in the form of a deep anterior lamellar keratoplasty. Now, if you need to replace the posterior part of tissue, like the endothelial cells have been damaged, you can do either a desec, where a little bit of stroma and all the endothelial cells are transplanted, or a demec, where only the decimase membrane is transplanted. Then you have the limbal stem cell grafts. That can again be of two types. So if we are talking about allografts, that means donated cornea, then you can take chunks of tissue from the limbus. Now the limbus bears the stem cells that grow into the transparent corneal epithelial cells, which are very important for vision. So that's how this is different. It should be non-vascularized, it should be transparent, it should be dehydrated. So these properties are very exclusive to the cells that generate the corneal cells. So these limbal stem cells can be transplanted, and they can be transplanted in chunks, or they can be transplanted in peaks into a new cornea to produce clarity in that cornea. In case it is edematous, in case it has got vascularized, in case the epithelial cells have degenerated or been destroyed by a superficial shock. Then Bowman's layer transplantation, this is a rather new subject. This is used in patients with keratoconus. So now what, and in patients who may have some sort of fibrosis following refractive surgery. So in Bowman's layer transplantation, you transplant the Bowman's layer exclusively, which is the barrier between the stroma and the epithelium. So doing that increases the stiffness of the cornea in a condition like keratoconus, so that the progression is barred. It can also produce a barrier between these two layers of the cornea, and thus prevent subepithelial fibrosis of a very wild nature that can rarely happen following refractive surgery. It usually happens in people who may be prone to having keloid formation. Now these are some of the cases that I would like to highlight. This is primarily what I do. So now this is a perforated fungal keratitis. You can see how the entire cornea has been destroyed, and a large part of the cornea. So it's this part, in the center, which aligns with the pupil, is responsible for light transmission. So if you had a small, an ulcer over here, you won't be that much concerned after you get rid of the ulcer, because the scarring will be here. At the most, you might have a refractive error that you may need to treat. But if it's in the center and it has destroyed such a large part of the cornea, now this is an eye where the corneal tissue is all mulched and is hanging out. And you have a very shallow anterior chamber, and the next would be the expulsion of the contents of the eye, those that are perfectly normal. A very clear lens, a good pupil, a good retina. So now this would be the cause for blindness in that person, secondary to this ulcer. So this is what needs an emergency transplant. Now this is another person with a penetrating injury. Now a lot of penetrating injuries happen. They can be in the limbus, sides, anywhere, but now you can see a big tear here. This was a screwdriver that went into his eye. So he was doing something, and then it just flipped back and went into his eye all the way in. So that produced a large zigzag central tear. Now the primary step we do, like in any surgery, is to suture it up. But you'll notice over here that the suturing itself is right in the center. So even if the eye heals and the tectonic support of the eye is retained, there will be such an opacity in the center that he's not going to have any useful vision. So at a later date, he will need a corneal transplantation. And such are the cases where you need a total penetrating keratoplasty. And this is briefly the procedure of the keratoplasty. You mark the center of the donor cornea. So this is a corneoscleral rim that comes to you in a preserved medium. Cortisol is what we use. And then you cut out a small graft from that. That's what was done in the previous one. Now this is the recipient eye where you refine the center after making marks. This is to align the recipient cornea with the donor cornea. So once you make a small trephination, you cut out the cornea and then you bring in the donor cornea. Now you have all the lines there through which the sutures are to pass. So first the 4 cardinal sutures are put, followed by another 4, and then around 16 sutures are put, You may put a running suture to maintain a torque after that. So now, in the end, the knots are buried because otherwise the patient will be extremely sensitive to the foreign body sensation. And then you also have to check that there is no leakage. You have to check that the thing is watertight. So what you saw right now is a penetrating gastroplasty. Now peritomy has been made before that. So this is because it was a heavily scarred eye. Now here we are seeing another patient who had Stevens-Johnson syndrome with a moderate corneal scar. Now the main thing this person had was a limbal stem cell loss, as you can see here, and some symblepharon formation. This requires two processes. Now limbal stem cell loss has caused the conjunctivalization of the cornea, where the vasculature has grown in and the cornea, part of the cornea has become opaque because now it's covered by conjunctival epithelial cells and not the transparent corneal epithelial cells. Now here are the symblepharon on the other side, you can see. Now this means that the formices are very close and attached to the bulbar part of the conjunctiva. So there is no fornix inside. The closure and opening of the eye is very abnormal. The eye is extremely dry. So here you need an oculoplasty procedure first before you can go ahead with the corneal procedure. You need to form the formices. You need to make sure that the surface is smooth and not as undulated as that one over there. So you may need an amniotic membrane transplant to do all that. So now this is the result when you do an allo-limbal stem cell graft. So here was the scarred cornea with growth of the conjunctiva onto it and approaching the visual axis. So once you dissect out the scar and apply limbal stem cell graft, which is usually taken in the form of bands, and applied to the limbus, then that adheres to the underlying tissue and produces new cells that populate the cornea. New corneal cells that populate the cornea. Now this is an advanced scarring in Stevens-Johnson syndrome. You can see how paper-like the conjunctiva has become. So this has a very, very poor prognosis. What it needs is a penetrating keratoplasty along with a limbal stem cell graft, and that doesn't have a good prognosis at all, because you already are scared of the graft rejection. Along with that, you want the limbal stem cells to adhere. So that is a very difficult proposition. Now here is another corneal melt. This is a person with rheumatoid arthritis. So you can see that over here, the cornea is quite thin in the center. Over here, you can see more of brown in the center, which means that it's extremely thin and only the DM, decimase membrane, is present in that location. The rest of the stroma has melted. Now, how much you treat this eye, this patient is not going to get better until the autoimmune systemic condition is controlled. So it is in this situation that we need to work closely with the rheumatologist, and their treatment works miracles. But it may scar the cornea. Usually such corneas get scarred because scarring is a normal process of healing, even in the eye. And then again, you would need to look at a corneal transplant. On the other hand, had this perforated, that would have been an emergency situation where you would need an immediate tectoid graft. Now this is a cornea that has been glued following a corneal melt. It was going to perforate. Now we have a lot of biological glues. This is cyanide glue that we use for the cornea, and that can make sure that temporarily the cornea is safe till a transplantation arrives. Now this is another condition, corneal dystrophy. So dystrophies are of many types. It can affect any layer of the cornea, may be present from birth, which are very severe. But some of them, which are not so severe, are may be passed down in families, and they present sometimes during the second or the third decades. So such are people who have the potential for vision. Now, why does corneal dystrophy affect them? It's in two ways. First of all, it produces bad vision, and secondly, it's very irritating because there are a lot of recurrent epithelial erosions in people with corneal dystrophy. And that keeps on irritating the eye. It's very painful. So these are two indications for which a corneal transplant may be needed. So if it's a superficial dystrophy, you can have a superficial lamellar transplant. But if the whole cornea is involved, you may need a penetrating keratoplasty. So now this is a deep anterior lamellar keratoplasty done for a superficial corneal degeneration. You can see that after a guarded trepanation, superficial tissues are dissected first. Then you go deep and dissect tissues so that you can reach up to the decimates membrane. Now this is the donor cornea from which the endothelium is being removed, so that donor cornea can now be fit onto the decimates membrane of the recipient cornea. This is deep lamellar, anterior lamellar keratoplasty. Then again it is sutured without puncturing the decimates membrane, so that now what is it? Now these are venting incisions that are being made so that there is no fluid between the interface. Now what is the advantage of this? Why not do an entire penetrating keratoplasty? Why go through all the hassle? We have found that the chances of rejection of such a lamellar procedure is so much lesser compared to a full thickness penetrating keratoplasty. So the chances of rejection of full thickness penetrating keratoplasty are much larger, and that has been significantly reduced by lamellar procedures. So this is a post-lamellar keratoplasty patient. You can see that this is the tissue retained, this is the transplanted tissue, and this is the junction of the host cornea and the donor cornea. So this much is the host cornea, and this shelf above is the donor cornea. So this is an anterior segment OCT picture. Now this is another patient with pseudophakic bullous keratopathy. Following cataract surgery, the cornea has become edematous. Now here is a loss of endothelial cells. Now it's exactly the opposite thing. So earlier we had loss of clarity of the upper part of the cornea. Now the cells in the lower part of the cornea are lost. So you can see the AS OCT shows a lot of undulations in the decimates membrane over here. The entire cornea is thickened in the center. So these are indications that the clarity of vision is lost. These are indications that without much delay, if you do a lamellar transplant, you don't need to go in for a penetrating keratoplasty before the rest of the cornea is destroyed. So in such a case, you can do a decimate stripping endothelial keratoplasty, which is called DSEC. So here, this is the donor cornea which is being kept in an artificial anterior chamber and dissected. So now here you are dissecting out the decimates membrane of the host cornea and taking it out of the eye. Now this small flap you see that you have dissected from the undersurface of the donor cornea is inserted into the eye, and then the eye is irrigated and the cornea, that lenticule, is kept in position. And then you just need to suture the incision. So you can see that there are no sutures in this form of surgery because there is a natural tendency of the donor cornea to adhere, and the provision of air bubble or C3F8 is another gas that you can use inside the eye to cause this adhesion between the graft and the host. And the rest of the function is done by the endothelial pump. So that is a natural pump present in the decimates membrane that can take fluid out of the cornea and throw it out. So this negative potential of drawing fluid from the anterior chamber into the external environment causes the graft to adhere to the rest of the body. Now this is how the eye looks post DSEC. You can see the graft over here is well adherent and the central part is clear, unlike the earlier pseudophakic bullous keratopathy. So now these are some of the forms that we use for social campaigning. So we actually explain to the patient. So these are some of the surgeries that are done as a part of the donor cornea utilization. So now coming back to the social issue. So we tell the people that eyes are a very valuable part of the human body, and donating a dead person's eyes can give sight to two visually impaired people. You can perform this miracle by donating your eyes after death to the nearest eye bank, for which you need the consent of your next of kin. So it's better you condition people who are going to stay after you to your wishes. Even if you write a will in this country saying that I want to donate my eyes, the next of kin has to consent to removal of the cornea. Currently, the availability of donor eyes do not meet the demand. Any person can be an eye donor. Poor eyesight and age make no difference. But persons younger than 18 years, before they agree to pledge their eyes, would need authorization from their parents or guardian. It is not against any religious faith. and it does not produce disfigurement or neither does it interfere with any ritual that needs to be performed after death. And as soon as possible, eyes should be removed, preferably within 4 to 6 hours after death, so that you should not sit over and keep on thinking about what to do. Eyes are not bought or sold. So then again, what is the eligibility to donate eyes? Anyone can donate their eyes. Now, who cannot donate their eyes? Even if you have cataract or glaucoma, or you wear spectacles, or you've undergone any procedures, you can donate your eyes. Now, when can you not donate the eyes? It's the same like I told you before. If you have such an infectious disease that is likely to be transmitted by the donation, do not volunteer to donate your eyes. Other than that, anyone can. Now, people who have done LASIK, there are two types of refractive surgery. You can have a surface refractive procedure like trans-PRK, which is done on the surface. Then there's another type of refractive surgery where a flap is taken and the examer laser is applied to the residual stroma to create the refractive correction. You have SMILE, where again you encroach inside the cornea of the eye and a lenticule is taken to produce a refractive correction. So in such cases, what is the situation of eye donation? You can donate part of your eye can be donated definitely, but maybe only a part of the tissue can be used. So the endothelium can be used for a resect like you saw there, or a DMEC, which is where only the dead space membrane is implanted, not the stroma. Then some part of the stroma can be used for a tectonic graft or reinforcement or a partial graft for perforated eyes. So don't rule out anyone. Anyone is a potential donor. And how to do the procedure? I mean, what to do after a person dies, which is very important, which is what I would like you personally, rather than whatever you saw and heard till now. This is what I'd like you to transmit information about. Suppose you're a house surgeon in a medical ward and someone has disease and someone comes to you to ask, okay, he was interested in donating his eyes. Can you tell me how to go about it? What should I do next? So there are some precautions that a person should take when you're trying to preserve that eye till the person who has to retrieve the cornea comes by. First of all, contact the required authorities within 6 hours of death. Switch off fans and keep an AC on if possible. That's to preserve the cells as much as possible, because oxygenation has ceased, and thankfully the eye is a non-vascular. The cornea is a non-vascular organ, so it does not depend on a continuous circulation for oxygenation. It can get oxygenated from the anterior chamber and even from the air. Though these functions are highly suboptimal following death. Close the eyelids gently. So a person has died in grief. If you leave the eye open, this happens even in ICUs where the eyes may be left open. So close the eyes gently and make sure that there is some sort of a wet cotton ball over the eyes, so that the cornea do not dry out, get a lot of epithelial defects, or become unusable for transplantation. Try to rest a diseased person's head on a pillow. So that is to decrease the vascularity in that region when the corneal scleral rim is taken out. Remember, though the cornea is avascular, it is taken out from the uvea. So, and the uvea is very vascular. So the corneal scleral rim needs to be peeled off from the uvea, and we try to decrease the vascularity there. Make sure that all the formalities have been done, with the death certificates, the consent forms, and all that. And anyone can donate their eye to any eye bank in India. The nearest one is the best place to donate. And even if you have filled a form, always tell them there's always an opt-out. We are not in an opt-out system. So that means that if you have filled an eye form in some countries, you're legally bound to donate your eyes, even if you change your mind later, even if your next of kin is not willing to do that. So, but here, we are in a system that even if we have donated our eyes, we have pledged our eyes, we can always say, okay, I changed my mind, I don't want to do it anymore, and opt out of the system. So unless, so it's not legally binding. So this I don't have connection for. This was just one of the campaign programs by a very active eye bank, that is the LV Prasad Eye Bank in Hyderabad. They do a lot of procurement of the cornea, transplantation, campaigns, education, and teaching of how to transplant corneas. So that is one very active eye bank in our part of the country. Then above all, the gift of sight is the noblest gift of all. So if you can encourage anyone to do that, and if you are the person responsible for taking this decision, if you can make the right choice, it would be a great gift. Thank you.